Our first topic for the program today is stress test, ECG, and spirometry examination. Did I say that correctly? That's a mouthful. And we've got two speakers joining us today. Let's first read the bio. I promised them I wouldn't read their whole bio because it's very impressive. So I'll keep it brief. So Prof. Derman is the head of division of sport and exercise medicine at Stellenbosch University. He's currently a co-director of the IOC Research Center in South Africa, serves on the International Paralympic Committee, Medical Committee, and heads up one of two FIFA Medical Centers of Excellence in Africa. That sounds amazing. Then we have Prof. Schwellnus, who is a full professor of sport and exercise medicine at the Faculty of Health Sciences, University of Pretoria. He's registered specialist sport and exercise medicine physician and is the director of the Sport, Exercise Medicine and Lifestyle Institute at the University of Pretoria. He has been the director of the International Olympic Committee Research Center in South Africa for the last 14 years. So these gentlemen are used to working with top athletes in the Olympic sphere. Thank you so much for joining us. Please come up onto the stage. Can we give them a round of applause, please? Thank you.
Right. Good morning, ladies and gentlemen. Can you all hear me? There's a lot of ambient noise here, but I'm going to try my best. So my name's Wayne Derman, and you've heard the introduction, so I'm not going to speak any more about that. I would just like to say thank you very much to the conference organizers for the invitation to be here today. So before I begin, I would just like to make a disclaimer that both myself and Prof. Schwellnus received travel funding and an honorarium for BTL for this presentation. Another disclaimer is that I also have purchased and own the equipment that I'm going to be talking about today. So I'm not going to be speaking about stress testing. I'm going to be speaking about evaluation of athletes that you might be doing in your practices, and really what you need to be on the lookout for when you're doing the workup with an ECG for a young athlete. And we're very lucky to live in South Africa. We're an exercise-mad society, and we all enjoy doing some form of exercise. And there are a lot of physical benefits and mental benefits of being regularly physically active. And I'm going to show you some old data that really talks to the risk of your first heart attack. And what you see here is that as you get more physically active, so you enjoy a greater percentage reduction in your risk of your first heart attack. So much so that when you are doing no exercise and do a little bit of exercise, you enjoy a 30% reduction in the risk of your first heart attack. So that is quite phenomenal, because if you take this effect and you could put it into a capsule, I could sell this drug to all of you. Yet a lot of people don't do it, and it's free to do. It's accessible for everybody to exercise. And it's not only your first heart attack. It's many different systems. There are benefits for every system, whether it's your bones for mineralization, whether it is the risk of dementia, depression. There are benefits to doing physical activity. But exercise is often seen as a double-edged sword. Often we have injuries that are associated with the exercise that we do. And often, well, not too often, but we know about these issues when they do happen, that when somebody dies suddenly during exercise, it makes headlines in the media. So we know that there is this entity called sudden cardiac death associated with exercise. And this is one of the reasons why we need to be doing an ECG and an evaluation of the athlete prior to them doing exercise. Luckily, this is not a common phenomenon. So if you have a look here, I draw your attention to this point, that the incidence of sudden cardiac death amongst young athletes is 1 to 3 per 100,000 person years. So it is very rare. But why we all know about it is that when we lose an athlete, the media really pump this up and we know all about it. So it's 9 times higher in male athletes, it's higher in athletes than in non-athletes, and there's a big difference depending on the geography, the definition, screening, and the ethnicity of the athlete, and I'll be showing you a little bit about this. So this is a very famous study by Barry Marin, who took 1,866 people who died suddenly. And he wanted to tease out all the people who were associated with exercise. So he took all these unresolved cases and blunt trauma and commotio cordis is when you're hit, for example, by the steering wheel of a car on the chest. He took all of those out. He took out the ones that were associated with heat stroke, drugs, pulmonary conditions, and other conditions. And he got this group of cardiovascular deaths of 1,000 odd athletes. He then was able, through the registry, to tease out those that were non-exercise related and those that were exertional or exercise related. He could have a certain group where there was no information, but there's a certain group where there was a lot of information about these particular people. And here at the bottom, you can see the various different causes of these deaths associated with exercise. So, for example, there is HOCM or hypertrophic cardiomyopathy, there's coronary artery abnormalities, there's myocarditis, ARVC stands for arrhythmogenic right ventricular cardiomyopathy, ion channelopathies, mitral valve prolapse, bridging of the coronary arteries, muscle, aortic rupture, aortic stenosis, Wolff-Parkinson-White, and some others. So my message of this is that there are a lot of issues here that can cause death. Some of them are structurally related to the heart. And I want to draw your attention to this one here, coronary artery disease. Coronary artery disease, if you're older than 35, is still the main cause of sudden death during exercise. But here you have a lot of these other issues. You might not have seen them, but I promise you they might have seen you in your rooms. So by examining, taking a good history, and doing an ECG, we can identify some of these causes and get them seen by the cardiologist way ahead of time when they present. So the way we do that in sport and exercise medicine is we have a evaluation called the periodic health evaluation of elite athletes. And really what this is, it's a full medical that we do on athletes. And there are certain areas, there's a cardiology assessment, and then there's every other non-cardiology system. There's a concussion evaluation, there's a dental screening, there's a musculoskeletal screening, there's specific issues related to female athletes, like energy deficiency, that we look for, and there are mental health issues as well that we screen for. But I'm going to focus in just on the cardiology assessment. So the cardiology assessment is not just an ECG. An ECG itself has limited value, but it is important that we have a history, physical examination, and resting ECG. On history, the 5 cardinal symptoms that we want to look out for are the following: exertional chest pain or tightness or pressure when you're exercising. Secondly is palpitations. Thirdly is excessive dyspnea. Obviously, we're going to breathe hard when we exercise, but dyspnea that's out of proportion. excessive fatigue, and exertional or unexplained syncope. And this is a very important thing that we need to screen for. If we also ask for a change in exercise tolerance, and we find that exercise tolerance has changed recently with these symptoms, then we have a flag to look out for certain issues on the ECG that might alert us. Very important is a family history of cardiac death below the age of 50 years old. And then very important is recent infection. Why? Because we know that myocarditis is such an important entity and is associated with sudden cardiac death. Now we move to the physical examination. When we do the physical examination, we want to go and evaluate the pulses. We palpate for 30 seconds, both left and right, both upper extremity and lower extremity, to look for a radiofemoral delay. We're going to feel the apex beat and make sure that the apex beat isn't displaced, because that is important, particularly if we're looking for a HOCM or enlarged heart. Then we're going to listen to the heart, both at rest and during dynamic movements. And these are important. There are 3 dynamic movements that we like to listen to the heart. And the reason we're going to do these dynamic movements is we're going to distinguish between physiological murmurs and pathological murmurs. So here are the 3. The first thing we're going to do is get the athlete from lying down to standing up. By doing that, we're going to decrease the preload. Now, when we stand up, if the murmur that you hear gets softer, then that is a physiological murmur, or more likely to be physiological. If the murmur gets higher, that's more likely to be associated with pathology, in this instance, HOCM. Then we're going to ask them to bear down against a closed glottis. This is the Valsalva maneuver. It also drops the preload, and the same conditions. It goes up in HOCM and it goes down in a physiological murmur. And then finally, what we're going to get them to do, and you have to do it with them, is you put your stethoscope in and get them to squat down, and you listen. If on squatting down, the murmur goes down, that is more indicative of pathology. But if you squat down and the murmur goes up, that is more likely to be physiological. We're also going to be on the lookout for very large, tall athletes, more evident in the American basketball area. But the stigmata of Marfan syndrome includes ocular or lens pathology, a whole lot of skeletal issues as well. For example, a high arched palate, pectus excavatum or carinatum, scoliosis, a wide arm span, arachnodactyly of the fingers, pes planus or hammer toes. And if one's going to do a assessment of flexibility of the various joints, the Byton score could score them at being hyperflexible. So those are your stigmata that you're going to be on the lookout for. Now we're going to move finally to the resting ECG. And I'm going to be speaking about the Seattle criteria. And the Seattle criteria were written by John Dresner and colleagues, and then adapted again later to put this ECG consensus statement together. And I'm very happy that these slides are made available, because the diagrams from this publication are very important when it comes to evaluating the ECG. The first tip I have is make sure you get the lead placement right. Have a look at the leads, they're all labeled. One of the pitfalls is that if you get this left and right wrong, and that sets you off on a whole different pathway. So if you get an abnormal ECG, the first thing you go and look at is left and right lead placement. Good. Then you do your ECG. Now, I know you can't read that, but this is the table from the paper which sets out all the different little things that we have to look for when we do the ECG. Not only is it one column, but it is two columns. But it is very interesting to go and read them. And what is nice is that they have summarized these into a traffic light diagram that I'm going to blow up right here. So here we see that there are normal findings. Here we see that there are borderline findings, and here we see that there are abnormal ECG findings. And each of these little points is set out. Now, why is this an issue with athletes? Well, when people exercise regularly, the exercise that they do can induce changes in the heart that cause the ECG to be different sometimes to what we would consider a squeaky clean normal ECG. But these are the ones here that are considered normal for athletes. That would be increased voltage criteria for left ventricular hypertrophy or right ventricular hypertrophy, an incomplete bundle branch block on the right side, early repolarization or a raised ST segment in that early phase of the J point, then T-wave inversion, if we see that followed by or preceded by ST segment elevation in V1 through to V4 in black athletes. And here there is an ethnic difference in black versus white athletes. If we see that in black athletes, that can be normal. The other difference is in young athletes. T-wave inversion in young athletes below 16 years old in V1 and V2 is normal. But if they persist through the later leads, particularly 4, 5, and 6 on the lateral side, that can be considered abnormal as well. Then, sinus bradycardia, ectopic atrial or junctional rhythm, first degree heart block, or a Mobitz type 2 heart block. Those are all considered normal for the exercising individual. Then you do not need to investigate that athlete any further. Then we get a number of borderline ECG findings. Left axis deviation, left atrial enlargement, right axis deviation, right atrial enlargement, and complete right bundle branch block. If we have only one isolated one of those, that is considered normal. If there are two or more, it is considered abnormal. And here we see all the abnormal ECG findings, including T-wave inversion, ST segment depression, pathological Q waves, complete left bundle branch block, QT, prolonged QT intervals that are not physiological, an epsilon wave, the Brugada condition that I'm going to show you, and another whole number of other conditions where you will need to say that this ECG is abnormal. We need to refer that patient on. What you refer on for, it's an echocardiogram and a cardiac MRI, which are typically the next evaluations that the abnormal person who has the abnormal ECG goes for. Okay, so what are the common pitfalls? Well, T-wave in standard lead 3 is not considered abnormal, and for the T-waves to be abnormal, you require T-wave inversion in both lead 2 and AVF. So that's important to actually know with the precordial leads. Remember that lateral T-waves in V1 through to V6 require thorough investigations, and go and look carefully at those, and remember the age of the athlete and the ethnicity. I've spoken about the black athlete repolarization pattern through V1 through V4, where that is considered normal. For T waves, Q waves to be significant, they need to be large. They need to be more than 1/4 the height of the QRS complex, or more than 40 milliseconds in duration. And then remember the borderline findings that I told you about. More than 2 of those borderline findings classify the ECG as abnormal. So my take-home message is that there are a lot of these criteria that have been simplified into a green, orange, or red criteria. Now, we spoke about the ECG that BTL has here at one of the stands. And why this is a future direction and why this is important is that that machine uses AI in order to assess the ECG that you have in front of you, and it puts it into those 3 categories. So please, if you want to have a look at this, BTL's stand is just down this first aisle here. After the session, please, if you want to go and have a look, go and have a look at the software and see how it does this. Point being is that you must still know that there are these things. So let's go through just a few cases that I want to show you. Okay, now I'm not going to pick on anybody. Usually at this point of the talk, I point on someone and say, come and read the ECG for us. Just know that when you see an ECG, it's good to have a system of evaluation. So it's rate, rhythm, axis, hypertrophy, ischemia, and morphology. And under morphology, you look at the P wave, PR interval, QRS complex, T waves, and then additional waves like funny forms like epsilon waves, delta waves, and a Brugada pattern. So when you go and look at this, remember I said that it's important to actually view the ECG in the company that it keeps. So this is a 21-year-old female swimmer who comes for their pre-participation evaluation, asymptomatic, no history of sudden cardiac death, normal cardiovascular exam. This ECG, although it has some few abnormalities, they are isolated, and this is considered a normal ECG. Now I'm going to show you another case. 15-year-old African male football player comes for a pre-participation evaluation. They're asymptomatic, no family history of sudden cardiac death. They have a systolic murmur, but the murmur diminishes with Valsalva. It is more likely to be physiological. Okay? But when you look at the ECG, you will note that there are inverted T waves in 2 and in 3. Normal in these. Is this an abnormal pattern? No, it's not an abnormal pattern. So again, you might be worried about this here, but if you apply the Seattle criteria, it is normal. Here we have a ECG in front of you that gives you cold shivers. Why does it give you cold shivers? Let's look at the person. It's a 36-year-old African male marathon athlete, comes for the pre-participation evaluation. They're asymptomatic, no family history of sudden cardiac death, but they have inferiorly displaced apex on cardiovascular examination. And what do they have here? The striking features. I'm not going to go through all the features of this ECG, but just have a look at the T waves here. That looks abnormal, first of all, but the T wave inversion in 3, 4, 5, and 6. Right the way through. Is that abnormal? That's abnormal. Okay, this person needs to actually go for a cardiac MRI and an echo, and this person had HOCM. Okay. Right, if one has a look at this, again, I don't want to spend too much time. I'm just going to point your eye to the most important. Can you see this area over here? High ST segment takeoff and down sloping. That is the Brugada abnormality. And this is a channelopathy which sets up for a fatal arrhythmia. And finally, if I go to the last case, this is a 28-year-old female netball player who has a history of short episodes of a racing heart, no family history, normal cardiovascular exam. Anybody see anything here? Well, remember that when you've gone through the whole thing and you've done the rate, rhythm, axis, hypertrophy, ischemia, morphology, and you've gone through the P, QRS, T waves, and you go to those added waves, then you're going to look for the delta wave, and here you see a delta wave in these. That slurred uptake there of the QRS complex, and that is the findings of a Wolff-Parkinson-White. And this person has risk of sudden cardiac death. They can go for an ablation of that bundle, and they can participate without risk going on further. So thank you. I'm out of my time. I'm going to now hand over to my colleague, Martin Schwellnus, who's going to speak about the other form of investigations we do often on athletes, and that is the pulmonary functions and lung functions.
Before we move on to that, does anybody have any questions for Prof? There's a question at the back there.
Thank you, Prof.
Thank you.
You indicated normality in the black athletes of inverted T wave in V2, 3. So what about
1, 2, 3, 4? Yeah, 3.
Yeah, what about the white athletes? What could one expect? Is there any variety in terms of what normality in that regard?
Yeah, it's an interesting finding, and this is done on huge cardiac registries all throughout the world, where they've had all of these so-called abnormal findings, and then follow-up MRIs and echoes. And that's over many years how they determined this change.
Any other questions? Can I ask a quick question? So, with this pre-evaluation, is there a variation in how you would carry that out when you are working with a Paralympic person who's disabled?
Yeah, that's a very, very good question. So the Paralympic athlete implies a whole different list of abnormalities. So it could be that you're visually impaired, could be that you have a spinal cord injury, or it could be that you have a limb deficiency. And the periodic health assessment for each of those is different. So it's very different. It's a bit more time consuming, but it's a great medical challenge.
Thank you. So we have one more question.
Just a quick question, Prof. Thank you so much. Yeah, for short and long distance runners, for instance, athletes, would the approach be exactly the same, or would you be more aggressive on the long distance runners?
Okay, so the question was about long distance runners? Yeah. No, this is how we would tackle it. Same thing for all athletes. And you know, the changes that we see physiologically, the important thing, because it is difficult sometimes to differentiate between a long distance runner and normal, is we can, if we're worried, we let them detrain. All the normal changes when you detrain, like the big left ventricle, recede to normal. Okay, that's how one of the... So that's one aspect, and then often, again, we can do other special investigations. But the workup of them, the periodic health assessment, is exactly the same.
Thank you so much. If anyone size questions, we'll reserve that to the end and let Prof. Schwellnus can carry on. And just to, Prof did allude to the slides going out. So because when you register for the CPD, we obviously have your email, so we will email you all a copy of the slides as well. And it is also being recorded, this whole program, which we will make available on YouTube or somewhere, and we will let you know where you can, if you want to rewatch, because I know it's quite a lot to take in. Okay, thank you so much.
Good morning, everyone, and again, thanks for attending the session. Thank you, Wayne, for a great talk. Thank you for the organizers for also inviting me to be part of this. Thank you to BTL for making yourself and the equipment and the stand available to maybe show some of these things to the delegates who wish to visit them. So I'm also a sport and exercise medicine specialist like Wayne, and we've worked with athletes and recreational athletes in particular also for many, many years. And one of the things maybe I just want to add to Wayne's presentation is that the older athlete, in other words, the recreational, perhaps even the older athlete, elite athlete, the approach to the cardiovascular examination needs to be one where we also look for coronary artery disease. Wayne made the point. And for that, adding on top of a resting ECG, even if the resting ECG is normal, in someone who's at risk, with cardiovascular disease risk factors, we add an exercise electrocardiogram. And so that was the reason we did change it a little bit, the talk from stress ECGs. The stress ECG is an exercise electrocardiogram. And the same equipment's also available, and maybe one can visit the stand for a demo of that. What I'd like to talk a little bit about is the other major system. We always talk about the cardiorespiratory response to exercise. And so I'm going to talk a little bit about what you can do to assess the respiratory health of the individual who's physically active. And we do that with many different things, but the baseline spirometry would be one. So why spirometry? Why is that important for us to just re-look in our practice? Do we know how to do that? Do we have the equipment to do that? And why should we do that? So I want to just point out in this one slide the burden of chronic lung disease or lung disease amongst the general population. And there's good statistics that chronic lung disease is one of the 4 major conditions that are responsible for most deaths. We call them the non-communicable diseases, and chronic lung disease is one of them. So in your practice, you probably do see these patients. We also understand that particularly in countries like South Africa, there may also be a high burden of occupational lung disease. There's just been a very recent publication looking at minors where the prevalence is around 20% or so of various lung diseases. Then also, what about the future? There's a substantial interest in the burden of respiratory disease, not only lung, but respiratory disease related to air pollution, including chemical pollution, particle pollution, and pathogens like fungal disease, allergens, etc. That I would normally term the air we breathe these days is not the same as 20 years ago or 100 years ago. And if anything, it's going to get worse over the next 5 to 10 years, adding to this burden of chronic lung disease. So with those 3 points, hopefully I've made you aware of the importance in your practice to consider not only a history but and a clinical and physical examination, but possibly including basic spirometry as part of your assessment. Focusing now on the recreational athlete and also perhaps the more elite athlete, I was part of an International Olympic Committee consensus that focused on respiratory disease in athletes. And if you're interested, you can let us know and we can give you all the publications out of that. But one of the things that I've learned from my colleagues, mostly from Europe, and particularly London, is that if I look at a group of 1,000 physically active individuals, or elite athletes particularly, and I do the necessary investigations to look for what we call as a sort of a basket term, lower airway dysfunction. You may know that better as exercise-induced asthma or exercise-induced bronchoconstriction. If I take these 1,000 athletes and I test them all, whether they're symptomatic or asymptomatic, I will find that on average, 20%, every fifth athlete will have evidence of lower airway dysfunction. So we know that lower airway dysfunction, or EIB, is more common in athletes than non-athletes. And so you may say why that is, and we don't quite understand all of that. But one of the things we do know is that when you exercise, Wayne showed that great slide of thousands of runners. When those runners run, they change from nose breathing to oral breathing. When you change from nose breathing to oral breathing, your filter is gone. Your air goes straight into the airways. The polluted air, the chemically polluted air, the particles, the fungal spores, the allergens, and then most importantly, the dry air and the cold air goes into the upper airways and then the lower airways. And so that has a potential for irritating the airways. It can either generate an allergic reaction or simply just an inflammatory response to foreign particles. And we call that a lower airway dysfunction. So it's not surprising that when you have a physically active individual, that they are much more likely to have lower airways dysfunction than somebody sitting and doing no exercise. On the right-hand side here, there is, and this may, I just want to point out to you that we know, this is the slide that shows the prevalence, percentage of athletes, whether they're recreational. We're talking about 18% of recreational athletes and up to 30% of elite athletes. So recreational versus elite, elite have got a higher risk, probably because they train hard, hours of air that goes past the filter, not through the filter. Team-based and individual sports. And then I want to just point this bottom one out here, that if one group of athletes that really are prone to lower airway dysfunction, it's the aquatic athletes, swimmers. And one of the reasons for that is possibly related to chlorine exposure in the air just above. As they breathe in chlorine-related air. So I just want to point these things out so that you have an understanding that although we say 20% of athletes have evidence of lower airway dysfunction, it varies slightly. In South Africa, we don't really have winter sports, but our colleagues in the Scandinavian countries have got a major problem with that. The cross-country skiers, endurance skiers, for example, are exposed to very, very cold and dry air. And there is some evidence to suggest that those may actually suffer from a kind of occupational lung disease, because there may or may not be some irreversible change from chronic cold, dry exposure. But luckily, that's not our problem, unless you've got an athlete who visits, what is it, Tiffindale, regularly. But they have artificial snow anyway, so maybe that's not as cold as normal. All right, so what I want to take you through now in the next 10, 15 minutes is just to consider spirometry as part of your office-based investigation of individuals, particularly if these are recreational or elite athletes. And as Wayne very eloquently highlighted, and you do this periodic health assessment on them, or pre-participation assessment. So consider the potential risk that they have by speaking to them, getting a history of any symptoms, getting a history of their allergies, for example, getting a history of whether they suffer from any nasal obstruction. And there are some really good screening questionnaires available that you can administer to your athletes. And then, of course, if they have got any symptoms, particularly any shortness, excessive dyspnea, Wayne spoke about that, dry cough during exercise, any wheezing, and any obviously chest discomfort. So if you have a suspected athlete, then it would be worth considering spirometry, and maybe the high-risk athletes as a routine. So spirometry is the most common test, office test we have to assess the pulmonary system. And really, if you're not familiar with it, I'm sure most of you are to some extent, it really is a procedure that is an office-based procedure. And you need equipment. And again, I want to direct you to the one stand here from BTL. They've got equipment that is very portable, quite affordable, and very easy to use. And what you do is you really get the individual to do a resting breathing pattern for a few seconds, and then you ask them to do a deep inspiration, and I'll go through the procedure in a little bit more detail, and then a forced expiration, and then a deep inspiration. And really what you measure is two things, volume, and you measure flow. And then you get the so-called flow-volume curve. And when you get the printout, or you have the choices of all the parameters you measure, there are probably 15 different ones. And I'm not going to go through all of that, but what you want to do is you want to look at the volume, the forced vital capacity, and specifically the air flow, the rate. That's the expiratory volume in the first second of that forced vital capacity maneuver is one of the parameters that you want to focus on, for example. Interesting thing about this test is its applications. So if you just do it at rest, they sit in front of you, it provides value, but we can do various provocation tests. Provocation test is when you get the individual in front of you to do something that is likely to provoke or simulate what happens during exercise. And so we talk about provocation tests. And there are direct and indirect provocation tests. Direct provocation test is if you administer a chemical that irritates the airways. Most of the time we don't really use that because it's very sensitive but not specific. So I will go through the most important indirect provocation tests that we do in a moment. On the right-hand side, I just want to direct you, you'll get these slides to this publication, which is a very important one if you want to do the test correctly. And I'm going to spend a bit of time on what are the indications, what are the contraindications, and how to prepare your patient to do this right. Because if you don't do this test correctly, you get the wrong diagnosis, perhaps either making a diagnosis when there isn't, and also missing one. So this publication lists and discusses in quite a lot of detail all of those points on the left-hand side. And I don't really have time to go through all of that. So I will just focus on a few of these, but I want to make sure that you have a resource that you can go through. If you're going to do this routinely, I would suggest that you take a cup of coffee and you read through this for 10 or 15 minutes. So let's first just give you the four main indications. When do you consider doing this? And the first one is just to make a diagnosis. And that is when I spoke to you about the symptoms or signs, or perhaps if you've got abnormal laboratory test results. For instance, somebody who's got a very high IgE as a screening test for allergies. You can obviously diagnose a variety of conditions, diseases or disorders. We use it to screen individuals, high-risk individuals. I'm not going to speak about preoperative risk, but the anaesthetists do that for that reason, and also for us to track over time what is happening, prognosis. I think the second indication is monitoring, and we use that quite a lot to monitor progress, particularly in response to treatment over here. And then in the chronic condition, you can monitor for disease progression. So I'm not going to go through all of that, but the point about is the second indication is monitoring. The third one, again, not so much in our sphere, but in terms of assessing patients that are joining us for a lifestyle intervention program for chronic lung disease, and we can monitor what happens to both disease progression and also in response to our treatment. And there may be other situations related to occupational lung disease where you want to monitor the lung function over time and maybe in screening. And then there's a sort of a basket of other indications. We do quite a lot of research, so the first one does apply to us. Epidemiological surveys, the data I showed you come from that kind of indication. And I think the last one is to assess health status before at-risk physical activities. And remember, the physical activities may not be recreational exercise. There may be physical activity, occupational physical activity related things like firemen and so forth. So those are the indications, 4 big groups. What about contraindications? And I'm not going to go through the details of the list, but just be aware that you just need to check that. And I would say, if you just think firstly, whether there's perhaps an increase in demand for the heart muscle or changes in blood pressure. Because Wayne spoke about the effects of a Valsalva maneuver, because essentially you do that. So just be a little bit careful about things like arrhythmias in an individual, or non-compensated heart failure, etc. So just be aware of myocardial demand. Then, because you're also doing a Valsalva intracranial or intraocular pressure, it's quite rare, but just be aware of that. Then another one, which is more like a relative contraindication because it'll just cause discomfort, is sinus and middle ear disease. Maybe be aware not to do this within a week after some surgery. And then also increases in intrathoracic and intra-abdominal pressure. And again, a general one would be any thoracic abdominal surgery in the last 4 weeks. Now, you may not, certainly in our work, we don't really see those patients, but you may do. And then, of course, just be aware of infection control issues. In an individual who's got an acute infection, just be aware that, use disposable mouthpieces and make sure the equipment is sterile. All right. Spirometry can be influenced by the variety of things the patient, the individual can do before you test them. So this is a potential error if you don't take note of these and be aware of them. So I'm still going to go through them in a little bit more detail. The first one is important to us. If somebody's just gone for a run, they come into your consulting room and you test them, you're trying to identify lower airway dysfunction, they may be in the so-called refractory period where there's a chance that you will have a false negative test. Smoking, vaping, various consuming intoxicants, and you can probably take all of that and say nothing within the last 24 hours is a good one. Be aware of restrictive clothing, because we're going to ask them to do a deep inspiration and a deep expiration, so restrictive clothing can also influence your result. Then the other thing is medication. So here be a little bit careful. If you have a brittle asthmatic on treatment, probably this will be someone under the care of a pulmonologist. Don't just withdraw the medication and test them. Again, it depends. Do you want to make a diagnosis, or do you want to monitor them? If you want to monitor their response to medication, you don't obviously withdraw the medication. But sometimes maybe they have been put onto medication kind of on spec because of suspected lower airway dysfunction, and the diagnosis hasn't been confirmed. Then these are some guidelines, whether you've got a short-acting beta agonist or a long-acting beta agonist. These are the guidelines for withdrawing the medication for a time period before, in order to test them to make a diagnosis. So just wanted to put this up. If you want a general rule of thumb, it's probably a good idea to withdraw these medications for at least 24 hours before. So I tell the patients for 24 hours before longer. It's only the really long-acting muscarinic drugs that are a problem, that you may need to have 2 days. But just be aware of this so that you don't get again, a false negative result if you want to try and make a diagnosis. All right, I am probably not going to, in the interest of time, go through this whole procedure about the maneuver, but just be aware that, again, the way you conduct the test will determine whether or not this is going to be an accurate test. So there is a whole procedure, and maybe the suggestion I have, And if I'm correct, BTL will have mouthpieces, and you can go and do the test yourself if you're not that familiar, and go through the procedure of just doing it correctly. The point about this is do it correctly. I want to show you this, and I spend a little bit of time on this because this is very important. The question is the test that you've done, going through a few inspirations, then a deep inspiration, a hard, fast expiration, and then a deep inspiration, is that a so-called adequate, correct test? And really, the first thing is simply to look at the flow volume curve, expiration and inspiration curve. And it should look like that. But you can divide it up into these phases, and you want to go through those 6 or 7 points, a bit like the ECG with the PR interval and P-wave, PR interval, etc. Go through that and make sure that all of those are met. An instantaneous start of the exhalation, not one that has a little bit of a dip. A rapid rise, that slope of number 2 is a rapid rise, not a slow rise. A sharp peak is number 3. Then a smooth, and very important, is a continuous fall of that flow without interruptions. And if there's a persistent interruption, it may indicate, for instance, upper airway obstruction. And a gradual fall at the slope of that curve is not linear. It goes and dips down. And then with the deep inspiration, a smooth, continuous inhalation. So if you see that curve, that's great. Do you just do one test? No. Minimum is 3 tests. And then number 7 applies. Do those 3 tests look the same? Are they reproducible? So if you've met all those criteria, then you can be quite confident this was a good test. And then you can get the results and interpret that appropriately. So that's a good test on the left. And so here's what the test should not look like, okay? So look for that slow start. I explained that before. Look for the slow rise. That's not correct. Look for the broad late peak, number 3, not correct. A very important one is number 4, which is erratic flow. And if that is persistent, that also helps us in the diagnosis. Look for the abrupt, whether there's an abrupt return to zero flow, number 6, incomplete inhalation. And then if every one of your 3 tests all look different, then you're not on the right. Then you just continue, have to do that and get the technique. Go back to those 7, 8 points of the technique and get that right. So I've spent quite a bit of time on this because it's really, really important. So this is the resting test. And if you have an abnormality in the resting test, and we normally say that is that if your FEV1, forced expiratory volume in the first second, drops by or is lower than the standard for that height, weight, and ethnicity of the individual, you may want to give them a bronchodilator and see the response. But when we see athletes, we want to do a bronchoprovocation test, and we use exercise as a bronchoprovocation. Like I explained to you, the airflow goes through the mouth. I just want to indicate to you that also you need to do that right. An exercise test, you may have to do that on several occasions. You certainly want the test to be during exercise that lasts for longer than 6 minutes at a high intensity. Heart rate above 80% of their predicted maximum heart rate. And the best is if you can do the test in the conditions where they develop symptoms. So in our practice, what we often do is we would get the patient to go and run outside. Now, that may not be in the same area. If they live in an area where there are lots of allergens, you may have to rethink about doing that. But you can certainly control humidity. You want to as dry air as possible. And you want to not get them in a hot environment. You want to have a cool, dry environment. So we sometimes do that in a laboratory. If you have a swimmer, and in our case, we have a swimming pool right outside. We get them to do a test, swim, and come back and do the test. And then remember, you do a pre-test, and it's very important that you do it at post-test intervals, at least 10, 15 minutes, several times, for example, at 5, 10, and 20 minutes. The reason is because the abnormality takes a bit of time, and usually the 5 to 10 minute post-test is most important. Okay, so that's just important, and then we use again a decrease in the FEV1, made more than 10% as an indicator of lower airway dysfunction. We have very sophisticated equipment in our laboratory where we simulate cold, dry air. And we do that when an athlete comes in for the test, and we expose them to high volumes of cold, dry inhalation, high minute ventilation for 6 minutes. And you can do that if you control the inhaled air by adding carbon dioxide to it. Otherwise, they get hyperventilation syndrome. To balance it, we have nitrogen and normal oxygen. So this is called a eucapnic voluntary hyperapnea, or EVH test. This is just the equipment that we have. So the gas cylinders have got 5% CO2, and here's an individual doing that test. Not that easy. Breathe hard and fast for 6 minutes. But this is the gold standard to diagnose lower airway dysfunction in athletes. So this is obviously not a test that you may have, but in an individual where you suspect that, but just the testing doesn't show it, then it would be appropriate to refer to an EVH test. This is just an example as a final slide to show you what an EVH test result looks like. That's the percentage change on the left-hand side. The red bar, the red one, is the FEV1. I've highlighted here the FEV1 compared. This is the pre versus the 5-minute post, and this patient had a 10% decrease, greater than 10% FEV1 at 5 minutes. You will see it was also at 10 minutes. But also notice that other parameters, which I haven't spoken about, the mid-expiratory flow rates, were significantly decreased, 30% decrease. So this is someone who has a positive bronchoprovocation, or indirect bronchoprovocation test. And here's the thing, is you use exactly the same testing equipment, but you just do the provocation test. So let me finish off there, and I'm happy to take some questions. Maybe Wayne, you want to join me if there are any other questions to Wayne as well. We are at 10 o'clock, and if we... Sorry? Okay, all right. Okay, if there are some questions, and I think Wayne and I will probably spend a few minutes at the BTL stand if you come and chat to us about anything. But if there are any questions.
Yeah. Can I ask you a question? Thank you for a very good talk. I just want to ask you, do you see an increase in respiratory burden after COVID? Because we certainly see it in our patients.
Okay. Thank you very much for that. So I didn't speak about another indication, which is, the whole concept at the airways become very sensitive in response to infections. So it's not only COVID, we see it after bronchial viral infections and bacterial infections. But the issue is, how long does that last? The normal pattern for post-infective bronchial hyperreactivity is about 6 to 8 weeks. If it lasts beyond that, we probably need to investigate them further. And certainly COVID has risen the interest and has made us very aware of that concept. Although we've seen it before with other conditions. So my rule of thumb would be 6 to 8 weeks to maybe have an abnormal spirometry but if it persists after that, probably referral to a pulmonologist.
Any other questions? We have one here.
Yes, just a quick one. Thank you very much for the talk. Just want to find out, it's just out of, when you do a spirometry on someone who's just done some exercising, maybe let's say on a treadmill, compared to somebody who's outdoors, would you maybe see any differences?
Okay, so if I understand the question correctly, is the post-exercise response, would it be different if you exercise in a gym versus outside? Okay, so what you're highlighting is the environment that is very, very important. And it relates to the testing. So in the past, when I was at medical school, and I was at a good medical school not far away from here, I've also worked at medical schools that are far away from here, down in the south. But the issue is The issue is that when we were taught, we did this in a laboratory setting, and I think we missed a lot of athletes because the environment was very controlled. So one of the things that we've learned is that you've got to really ideally test the person with symptoms in the environment that they get the symptoms. And it may be that you need to repeat this test within a few seasons. So in spring, when there's a high, pollens and allergens, you may need to do the test. I didn't speak about that, but there are some devices that nowadays you can give to a patient with an app, and you can get them to go and do it when they're running in the forest, if they always get symptoms in the forest, because there may be a series of trees there with an allergen that they're specifically allergic to. So what you highlight is the environment. So if you test them in the gym, you may get one result, and it may not be when you're out running.
Thank you. Any other questions? I actually have a question. So with every generation, elite athleticism gets younger and younger. So what does your research show you in terms of prevalence, number one, and then what recommendation, are there any things to consider when working with younger athletes? Does age play a factor at all?
In terms of spirometry, that's a good question. Maybe I'm going to divert that to Wayne. The answer is obviously, we do see, you're 100% right, we see athletes much younger. And in terms of spirometry, the most important thing is that when you do the spirometry, you need to enter the data about their age and so forth, because the norms are different for different ages. So that would be important. The question as to whether young athletes have a higher prevalence of allergies or lower airway dysfunction, I'm not really aware of any studies. Age, when we did the meta-analysis, age did not really feature into that, but we included really elite athletes or high-level athletes, not the general population. Wayne, I don't know if you want to comment on that.
Thank you so much. Thank you both. Let me just give you a token of our appreciation. Then just to remind everyone that the slides will be made available. Those of you who have just joined us,